Okay. All right. Welcome everybody to the HSJCC CAMH Sexual Behavior Clinic's Lunch and Learn. Thank you all for joining us. We're asking that everybody please mute themselves just due to the high volume of participants in this session. And before we start, I would like to take a moment to acknowledge that the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. So my name is Patricia Pagnani. I am the program manager for the Toronto Bail program and the chair of the West Toronto HSJCC group. The mandate of the local HSJCCs is to engage in planning, coordination, and integration of services across sectors for individuals dealing with mental illness who are involved in the criminal justice system. We've got 4 locals. There's the Toronto West, North York, Scarborough, and the downtown group. And what we do is we identify local priorities and work together to address any issues while reporting to the Toronto Regional HSJCC to help inform systems planning at a regional level. So just some housekeeping items. If you're interested in joining any of the committees, please let us know in the chat box and our coordinator, Domenica, will get back to you. And also this session is recorded and it'll be uploaded to the provincial HSJCC site under the West Toronto and North York HSJCC resource section. Okay, and one last thing before I introduce the speakers, if you could at some point before you leave the session today, take a minute, I promise it'll take no more than 1 minute, to fill out the evaluation form in the chat box. It really does help us to plan for future lunch and learns. Okay, thank you. So we are so fortunate to have wonderful speakers with us today. Okay, I'm just going to ask.
Yeah, please mute yourself.
Yeah, thank you. So we're so fortunate to have 2 wonderful speakers to tell us more about the CAMH Sexual Behaviours Clinic. We've got Angele Boudreau. She is a registered social worker who's been with CAMH Sexual Behaviours Clinic since 2017. She conducts assessments and provides individual treatment, group treatment, and family support. She is dedicated to a client-centered and trauma-informed and anti-oppressive approach to psychotherapy, risk management, and capacity building. Her prior work experience includes municipal politics, pediatric brain injury, disability and disability rights issues, and senior care in outpatient, inpatient, and community-based environments. And we also have Carly Sims, who is a recent Master of Social Work graduate from the University of Toronto in the Social Justice and Diversity field of study. Carly currently works as a social worker in the Sexual Behaviours Clinic at CAMH, where she is a member of the interdisciplinary team offering assessment and treatment to individuals experiencing sexual behaviors and or urges that could or have resulted in personal difficulties. Carly and Angele, I'll let you take it away, and thank you again for joining us.
Great, thank you so much for that introduction and for having us today. We're really looking forward to sharing more about our clinic. So we'll jump into it. I'm sorry, I'll be looking off to the side a bit because that's where my second monitor is with my slides, so apologies for the poor eye contact. So again, just to introduce ourselves, I am Carly and I'm a social worker at the clinic.
And I'm Angele, I'm also a social worker, as you heard, and thank you for the intro.
So for today's Lunch and Learn, we have a few learning objectives. The first being to share with everyone a bit more about the services that we offer at the SBC and also the referral process. We did make some recent changes, so for those of you who are familiar and have submitted many referrals before, we wanted to fill you in on those changes. We're also going to talk about a new program at the SBC called Talking for Change. And then we'll talk more about some of the reasons why we see people at our clinic. So talking about pedophilia and other paraphilias. And then we wanted to open it up for a bit more of a conversation around experiences and challenges working with people who have offended sexually. So again, this is just the agenda. I'm going to take it away for the first half, and then we'll swap over to Angele, who will cover the second. Okay, so the SBC. So like we mentioned, we provide assessment and treatment on an outpatient basis to people who have been convicted of a sexual offense and are serving a community sentence, or who are on formal mental health diversion for a sexual related offense. We also see people who are experiencing a harmful sexual interest or behavior that could or has already led to legal involvement. And then we also work with people who have intellectual disabilities or concurrent mental illness, substance use issues, who are experiencing challenges with their sexual behavior. So here's a bit of how people come through to our clinic. So the first step is a referral is submitted. I'll tell you a bit more about how referrals come through, but generally it's a probation officer, parole officer, or a physician in the community. An intake coordinator, who is another social worker at our clinic, will review the referral and make sure it's appropriate and complete. If the referral is not appropriate, it will be closed, and we generally send out more resources to the referral source, or it might be appropriate for our new program called Talking for Change, at which point we would forward the referral through there. And if it is appropriate, then we move forward to the next step, which is an assessment. So an assessment is completed by one of our clinicians at the SBC. It might be a social worker, it might be a psychiatrist or a psychologist. And after the assessment, included in that assessment report is treatment recommendations. And those treatment recommendations may be group treatment, individual treatment, or other community resources. So like I mentioned, we do an assessment. That assessment includes a clinical interview done either virtually or in person, and phallometric testing. So the phallometric testing lab, a small update, currently it is closed due to the pandemic. So how we're moving through this right now is we're making note of people who require phallometric testing and are consenting. And then once we're back open, we will move through that wait list and start scheduling people. So right now our assessment includes just the clinical interview and any collateral information, but generally it also includes phallos if the person is consenting and if it's clinically indicated. Okay, so a bit about the treatment that we offer. So the first one is mainstream group. So this is a group for men who have been convicted of a sexual offense and are on probation or parole. The group is generally around 14 to 16 weeks, and it's offered weekly, about an hour and a half each session. And this group uses a CBT framework, so a cognitive behavioral therapy framework, and is really focused on reducing someone's risk to sexually reoffend while also focusing on increasing competencies and personal strengths. The next group is the CSIM group. Again, if you're familiar with our clinic, you know it was previously called the child porn group or the CP group. So we've changed the group name, but this is for people who have prior CSIM charges or who are involved in CSIM use previously and want strategies to avoid using in the future. So really about identifying those risk factors and triggers to offending and developing strategies to manage that. Next, we have the mental health recovery group. So this is a group for men who have been engaged in behaviors that have led to legal involvement or sexual charges, or are engaging in behaviors that could, but who are also diagnosed with an acute major mental illness. And this group is much longer. It's about 20 weeks, and it's offered weekly for 1 hour. And then you'll see the next three are follow-up groups. So these all kind of use a similar idea. They're ongoing kind of maintenance style groups, meeting either monthly or bi-weekly. And they are for individuals who've already completed the prior groups or the prior group that was relevant to them, and then are looking for some ongoing support moving forward. And these are rolling groups, so people join at any point. The next one on there is the relationships and sexuality group. So this is a newer group, and it's for individuals who have an intellectual disability or dual diagnosis. It's actually developed in partnership with the Forensic Dual Diagnosis Specialty Clinic here at CAMH. And this is a psycho-ed group that also focuses on like psycho-ed and also risk management. And it's offered in person weekly. Right now, we've done one run through of it, and we're toying with the idea of making it ongoing. But that's for folks who have also already been convicted of a sexual offense or who are engaging in behaviors that could. Lastly, on there, we have individual therapy. So we do offer individual therapy. However, it is quite limited. We generally reserve individual therapy for females or trans individuals, people who require an interpreter, or people who may not otherwise be suitable for group. And family support is for family members of SBC clients. And that's, again, as it says, support, but also some psycho-ed in there. And lastly, we do offer consults for sex drive reducing medication. So what that looks like is the client would meet with a psychiatrist and kind of learn more about what that looks like and what medication is available. And that's for folks who have already engaged in psychological treatment and maybe didn't benefit or haven't succeeded in reducing their distressing sexual fantasies, or for people who are at higher risk of acting out on those sexual fantasies. So here we have just a few of the treatment modalities used by our clinicians, but also, as kind of previously mentioned, really interwoven into the groups that we offer. So we have acceptance and commitment therapy, cognitive behavioral therapy, dialectical behavioral therapy, and mindfulness. They're all slightly different modalities, but all really centered around bringing awareness or acceptance, trying to address emotions or thoughts in order to change behaviors. And yeah, Angele, I don't know if you have anything else to mention about those.
Yeah, I mean, I think that covers most of it. The awareness piece is really, I think, the first step for a lot of people, for reasons that make a lot of common sense, that if you're not aware of what's going on and what's sort of contributing to the problematic behavior, then it's really hard to change it. And the acceptance piece is a huge focus, and I'll sort of talk about this a little bit later. Acceptance, because we don't choose what our sexual interests are. People don't choose whether they're attracted to minors or coercive behavior. And so learning to accept it as a way to then build skills based on the knowledge of what is going on for you, and to reduce feelings of shame. But I'll talk a little bit more about that later.
Perfect. Thank you, Angele. So next, I'll talk a bit about our inclusion and exclusion criteria at the clinic. So we'll start with the inclusion. So we see clients who have previous criminal convictions or who don't. It's just important that they don't have any active legal charges that are sexual in nature. As I mentioned, we work with people who have a concern over a sexual behavior that's harmful and could or already has led to legal difficulties. So this includes people on probation, parole, or mental health diversion, folks who are 18 years and older, and as I mentioned before, family members of SBC clients as well. Exclusion criteria, so again, no pending charges that are sexual in nature and cannot be in the process of appealing a sexual offense conviction. We don't work with people who are experiencing sexual dysfunction specifically. We also don't work with folks who are concerned with hypersexuality, but if we do see those referrals pop through, then we're happy to send resources or more information about where you can get resources or support for that. We don't see people on recommendation from someone else. So if someone else is concerned with the client's sexual behavior, we also don't offer risk assessments or parent capacity assessments. This is something that we see a lot of people inquiring about. The Psycho-Legal Clinic at CAMH will offer risk assessments or provide information on where to get one, but we do not do these at our clinic. And lastly, our clinic is not a clinic for treatment in regards to gender identity. And again, CAMH does have the gender identity clinic, so we're happy to forward referrals over there. And then the last exclusion criteria that you'll see.
Learn on the Sexual Behaviours Clinic at CAMH.
Okay, and then the last exclusion criteria on there is the static 99 score of 0 or below. So this is a recent change that we've made within our clinic due to wait times and staffing shortages. And so this is something that we've come up with to help with that. And so far it has been the POs that we've had to explain this to, and the referrals we've had to let them know about this have been really accepting so far, which we're happy about. But so if someone receives a preliminary static 99R score of 0 and below, we're not assessing them at this time. And instead we would forward resources along to the probation or parole officer. And that's why, and I'll get into a bit more when we talk about what comes through with the referral, but this is why we have the legal history form that many of you I'm sure are aware of, and why we ask a lot of those questions so that we can score the static 99R for our clinic. Okay, so there's two main pathways into the...
Sorry, Carly, I'm just going to interrupt you for a second. There is a question in the chat box, and the question is, are the services only available to Toronto residents, or does CAMH offer teleconference sort of sessions for residents outside of Toronto?
Yeah, that's a great question, and we service all of Ontario. So, and with the move towards more virtual services through the pandemic, it's actually become quite easy for us to do so because a lot of our groups have been able to shift into virtual format, or treatment and assessment can be done virtually as well. Obviously, the phylometric testing is something that would be more challenging to accommodate because that is obviously in person, but we make it work when that comes up. So yeah, great question. Okay, so two pathways: med referrals and then the probation, parole, mental health diversion. So a med referral is from a physician, and how it works is the physician will submit the referral, any previous assessments, and then a bidirectional consent form, and that just allows us to exchange information with that referral source. And this is what we generally see is this is folks who are experiencing some type of sexual behavior that could and get them involved with the law, or already has, but they're done probation and they're done their sentence, but are still looking for a bit more support. And then we have the probation and parole. So this is where a lot of our referrals come through. There's a CAMH referral form that's faxed to us, and then a package, which I'll get into. And then we also have the mental health diversion referrals. So this is when someone is already on mental health diversion, and so they already have that case manager or court support worker, and either of those people can submit the referral on behalf of the client. We have a note there that if someone's on probation for a charge that's not sexual in nature, but they would like to receive services at our clinic, the PO does not need to be the one to submit the referral. It can be the client's physician. However, if the client is consenting and if it makes sense, sometimes it is nice to have that bidirectional consent between us and the PO to get more information and to all be involved in patient care. Okay, so what's included in the referral package? So we have the legal history form. So this outlines the summary of the current or the index offense and any priors, victim-related questions. We also have phylometric information form and consent form. We have, like I mentioned, the consent for disclosure, and then access to virtual care. So this just makes sure that there's no conditions that the person couldn't attend virtually, and if they can, what email address to reach them at. We also accept Youth Justice Act referrals. The steps for this are a bit different, and we actually ask that probation officers email the intake coordinator at our clinic before submitting a referral. We just have a few questions that we have to get the answers to, and we forward those to our legal department. And then our legal department lets us know if we're able to accept the referral or not. And the intake coordinator's email address can also be found on our website too. So this is just, again, reiterating that static score of 0 or lower, we're no longer assessing.
Can I just add something quickly there, Carly?
Mm-hmm.
With regards to the change of the static cutoff, certainly a big part of that was us being understaffed, as I'm sure many of you can appreciate in the organizations where you're coming from. It's also in line with the risk needs responsivity model of care, or R&R, as you might know it. So it's widely accepted evidence-based approach that indicates that the degree or the intensity of treatment should match the needs of the person. And so if their risk is deemed to be lower, no treatment or a lower degree of treatment is what's going to be recommended. And similarly, if someone is high risk, then we provide more treatment, longer treatment, more intense treatment. So those were sort of the two deciding factors, in case anyone was wondering about that.
Thank you, Angele.
Sure. So I'm going to talk a little bit about our new program called Talking for Change. This is something that's funded by Public Safety and CAMH, and more recently Google. It's an anonymous helpline, either by phone or chat from our website, for anyone that's concerned about their attraction to children, worried about engaging in an offense that actually involves a child in their life, or accessing CSAM material online. We also get a lot of calls and chats from people who might be concerned about the behavior of people in their lives with regard to inappropriate contact with children or sexual interest in children. So this is something that we offer in over 20 languages, not because we all speak over 20 languages, but we use a translating service. On the helpline is myself, 2 psychologists, and a psychotherapist, and it's open from 12 to 6 Eastern time. The first of its kind in the country. It's anonymous, and having to identify oneself is a huge barrier to treatment for a lot of folks who are struggling with a sexual interest in minors, because of our duty to report. If someone comes to us and needs help and has unsupervised access to children, or is in a position of authority, a teacher or camp counselor or whatever, then we're required to report, which is great. That's part of keeping children safe, and also acts as a reason for people to not, because it's so scary and can sort of blow up their lives. So people can contact us anonymously, talk about what they're struggling with. We provide resources online, or referrals for community therapists, or to our therapy program, which is also new. So we used to see folks at the Sexual Behaviours Clinic who had a sexual interest in minors as part of the main clinic, and it's since separated into this secondary program. This is free psychotherapy to individuals all over Ontario who are willing to identify themselves. So a little bit different from the helpline, where if you want psychotherapy, you have to identify yourself. And that is for regulations essentially on healthcare workers, or our responsibility for reporting and ensuring that we're providing ethical care. So free for folks in Ontario. There's also we have a partnership with the Atlantic provinces as well. So folks out east can also access free psychotherapy. And for other places in the country, we have referral therapists who we can refer to who specialize in pedophilia and unsafe internet use and that sort of thing. This is for individuals who do not have legal involvement. either in the past or at present. If people have legal involvement related to their sexual interest in children, then they go straight through the clinic in the ways that Carly was talking about. And for this program, people can self-refer. You don't need a doctor to refer or a PO to refer or your diversion worker or whatever. You can go online and just fill out the form. This is the landing page of our website. I would encourage anyone to go check it out if it's of interest to you. It's relatively new, so we're getting some chats and calls and have been seeing an increase recently. We will have advertisements going up on Pornhub soon, and we anticipate sort of an increase in traffic at that point, where there will be a pop-up or an ad that comes up when people are searching search terms that might indicate an interest in minors. So any kind of sort of like incest role play or teens or that kind of thing. So we're hoping that will be a great way, an opportunity to reach some folks who might be struggling. You can change the slide, Carly. Thank you. I'm sorry, I'm going to have to be telling her every time because she's generously offered to share it for us both.
There's another
yes.
good question from the chat,
Mm-hmm.
and the question is, if someone does not have status in Canada
Mm-hmm.
and or does not have OHIP coverage, does that exclude them from your services?
It excludes them from the therapy services. So we couldn't provide psychotherapy following their contacting the helpline, but we certainly get folks from all over the world chatting in and calling, and we do our best to offer guidance and do a little bit of sort of safety planning and risk management and talk about ways to prevent acting on any fantasies, urges, desires. If they're calling from like the States or the UK or Australia or Germany, there are programs like this in those places, and India as well, actually. But for some folks, the help would be quite limited to the helpline itself, which is really unfortunate, but sadly the case. It's a great question. So this, I'll talk more about this in a little bit. This might be a double up slide, actually, now that I'm looking at it. Here, we want to really highlight the difference between this sexual attraction to children, which is pedophilia, that's the interest only, and child sexual abuse. So when someone actually engages in sexual behavior with a child or children, we make this distinction for a couple of reasons. One being that people who do not have a sexual interest in children also offend against children. And people who have a sexual interest in children never do. It's sort of just because you have a sexual interest doesn't indicate or dictate how someone behaves. So important for sort of risk management and treatment planning and sort of knowing what services might be appropriate to someone who's offended against a child or not. And also in an effort to sort of reduce the stigma associated with pedophilia. That, like I mentioned before, we don't choose our sexual interest. No one does. And certainly a lot of the folks that we see who have a sexual interest in children would do anything to not live with that. And so using every opportunity to sort of make the distinction between these two, and that's why this slide is here now. And we'll return to that as well. I mean, this is the same thing. And sexual interest in children can motivate child sexual abuse, but not all people who are interested in children act on that interest, and not all people who abuse children are pedophilic. Other reasons why someone might offend against a child without that sexual interest, it can happen for a variety of reasons. Some people are opportunistic, some people have really poor social skills, perhaps are experiencing an episode of a major mental illness. There are all kinds of reasons why people might sexually offend against a child without that interest. So we'll talk a little bit about pedophilia and other paraphilias. Paraphilias meaning a strong and ongoing sexual arousal outside of interest in genital stimulation or fondling with physically mature consenting human partners. So it's either activities that are not considered sort of like the norm or directly related to genital stimulation or sex organs. So choking, for example, binding, tickling is another one, and others. So there's the behavior, or there is the actual target or the interest in something. So children, animals, shoes, feet is another one that's quite common, ears. So paraphilia is the interest itself, whereas a disorder is one that causes distress or impairment or leads to personal harm and or risk of harm to others. The distinction is important because lots of people have interests that are maybe not considered normative. And it doesn't mean that it's something that needs to be treated. If you are, tickling a partner's feet with a consenting adult, I'm not sure that it's necessary to pathologize that and treat it as if it's an illness. When we run into some trouble is when there are huge consequences of harm to self or others, or when someone is incredibly distressed by what they're experiencing, whether they're acting on it or not. This is the summary: interest, and then the second would be harm and distress. So again, the interest or attraction to prepubescent children, which is pedophilia. The other word that we use would be, it looks like I've been auto-corrected here. Hebephilia is the other one. So that's children of pubescent age starting to develop secondary sex characteristics. And then child abuse is the behavior. This is sort of, yeah, can you go back up to the first one, Carly? Yeah, so I won't repeat the same thing I've said a few times here. These are the definitions that use primary sexual attraction. Just worth noting that some people who are attracted to children are also attracted to adults. So we're talking about a primary sexual attraction here. This note that it does not discriminate is also this lack of choice. You cannot change the interests. And recent research has pointed to pedophilia and hebephilia as akin to sexual orientation, which I hesitate saying knowing that the history of gay rights movement struggled a lot with this comparison that homosexuals were going to sexually abuse children. This is unrelated to that. What I'm trying to highlight here is the lack of choice, being born with something, and the inability to change it. So the treatment that we do here focuses on, again, acceptance, changing behavior, and making sure that risk is reduced of harm, and awareness and coping with the distress that's associated. We're not in the business of conversion therapy. It's not something that we understand as even possible. I don't have the research here, and I can provide articles later if you're interested. There have been studies of the brain and brain differences in folks with pedophilia, and it looks like there's some sort of cross wiring where maybe where there's a connection for us between like parenting and nurturing, there might be a cross for other folks where there's, parenting or nurturing and a sexual response. So it looks like it's in the brain, and again, not something that people choose. I'm not a neuroscientist. I don't have the research in front of me. I'll just add that in. So if anyone's interested, I'm happy to share those articles. And chronicity, yeah, it doesn't change. Okay. These are some other common paraphilias that we ask about. Voyeurism, exhibitionism, those are people who would be have offenses. Indecent exposure would be exhibitionism, so flashing or maybe peeping. Masochism and sadism, sometimes that's like a coercive interest, so people who are sexually interested in rape or a resisting partner. I've got telephone scatologia, which is making dirty calls to someone you don't know. Coprophilia and urophilia, that's interest in urine and feces. Different kind of fetishes we'd have. Could be bondage, spanking, leather, that kind of thing. Bestiality, animals, and toucherism is also something that we see relatively frequently, which would be grabbing someone without their consent in public, or not in public, but generally happens in a mall or on a bus or on the street. Okay. So diagnosis of pedophilia made on the basis of self-report. So if people are saying, I have sexual interest in children, that's usually a pretty big indicator. Sexual history, sexual offense history, sexual victim characteristics, and fallow results or other assessment methods. And maybe I'll just briefly mention what fallow testing is for folks who don't know. It's basically the measurement of penile erection in response to stimuli depicting children or adults of different ages. So at our clinic, it's the changes in blood volume that's measured, and volume increases are taken as an index of relative attraction to different stimuli. Sexual history could be criminal charges, could be use of child sexual exploitation material or child pornography. Collateral informants, so if someone's partner has stated that they have indicated this interest, and then school records is something that also might be taken into account. Okay. So I mentioned when I was talking about change the barriers to treatment, this barrier of seeking help before coming into contact with the law, because it is so scary and can be so life-changing for people, they don't go until they've actually offended against someone. And then we have some barriers in terms of engagement. We see a lot of people who don't necessarily want to be with us, a lot of people who are on probation, and maybe that's part of their treatment. So another huge part of what we do is trying to provide treatment that's meaningful, whether people are super psyched to be there or not. And then stigma, of course. Okay. We'll open this up to folks. You use the chat or unmute. In your experience, what's been difficult of working with individuals who have offended sexually, either against a child or not, or maybe what do you think could be challenging in working with this population?
I think if people could raise their hands, then there could be a bit of order in terms of input.
Mm-hmm.
Maybe you can ask the question again.
Sure. Any challenges you've had in the past working with folks who have offended sexually, or a challenge that you think could arise? I see. Is it Narissa? Excuse me if I mispronounce
It
that.
is. It is.
Hi.
Hi. I think, like, I have never personally worked with folks that have offended, but I think that um, knowing knowing that it is that people do not choose to act out in these indiscretions is not like it's not a choice that they have. But I find that it would be a very serious issue, and I would think judgmental for a lot of people, and there'd be a lot of stigmatization attached to it because a lot of folks don't understand that this is not a choice, that this is actually a disease.
Totally. And I think I just want to make a quick note that absolutely people can choose whether or not they act, but do not choose the interest, and that it's something that they live with and struggle with, which often um, it's very challenging to control without the help. But yeah, feeling judgmental, I think I don't know how many times I've heard this where, you know, child abusers are worse than murderers, or, called monsters. Like, it's no secret the way that folks with pedophilia have been depicted culturally in movies. We see it all the time. So for sure, I think we we contain those biases, whether it's with our permission or not. I think even just by growing up in the society that we do, for sure, that is a challenge. Yeah.
Sure, because I think that, like, we're predisposed, like, at a young age to to seeing stuff like that, to seeing it in movies, like you said, to hearing older adults around you talk about that, right?
Totally.
And
Yeah.
they're towards it, so we're predisposed to a prejudice of being judgmental and not understanding that this is a disease and not a choice, these
Mhm.
thoughts, which is quite sad.
Yeah. Yeah. Yeah, it is. And I think helpful in cultivating empathy if there is acknowledgement of that lack of choice and how much people struggle. So thank you.
Yeah. You.
I think it was Tammy who was next.
Hi.
Hi.
Sorry, I joined in late. Enjoy your presentation as always. So I run a sex offender therapy group in my private practice with a forensic psychiatrist. And I think that we get a lot of referrals, and it seems to be that people that refer tend to want to just focus on the offending behavior without really realizing that it's such a complex problem. So, I mean, a lot of people that offend have gone through trauma themselves, working through periods of shame about what they have done, but also how they're viewed in society, things that have done to them, the trauma of offending themselves, right? So it's a very complex problem that goes beyond just treating the offending behavior itself. And I think that's hard to explain to some people that are not always in that role. And then additionally it's such a wide variety, like it's you get such a wide variety of patients, right? So you never know, sex offending and sexual assault can be very diverse in terms of the actual behavior that led to those offenses. So I tend in groups, you could get somebody that maybe grazed somebody in public versus forcible penetration, and how do you work with all of that together? So it can be very complex, and it's not always addressing just the behavior itself, but all of the back history that somebody has.
Yeah, you're really speaking my language right now. It's so true. And I think this is the best we can do for people is humanize them and understand them as whole people with whole lives before this happened, and that they didn't wake up one day and want to hurt someone, either through traumatic experiences of their own, or self-esteem issues, or whatever it is that they're coming in with, which of course is not an excuse, but contributing to behavior. And I will say, similarly at our clinic, our approach for treatment is a holistic one. And so in addition to the offending behavior, we're also focusing on helping people build a life that is meaningful. And and that also reduces risk. Like if you have more to lose, then chances are it's going to be really demotivating for engaging in behaviors that are really harmful. But that's, yeah, such a good point. Thank you.
Yeah, absolutely. And I just, again, want to thank you both for the invaluable work you do and the empathy that you give people. It's really invaluable.
Oh, thank you, Tammy. Likewise. We have 3 more. I think we might have time. I think Kathleen, you are next.
Okay, hi. Sorry, my mic was off for a second. My thought process around this question is really similar to the way that Tammy actually described, so I don't really have much more to add. I'm really just going to be piggybacking off of something that was really well illustrated. But I think the overall idea too is just the idea of we think of people who who engage in sex offenses, we really view them two-dimensionally until we're actually working with them one-to-one. And I know myself who only worked with women up until I moved to Toronto. I was only working with women. I was working within domestic violence, working within case management. I think that I saw sexual assault and also pedophilia as a really two-dimensional offense, where I didn't really recognize like what individuals who are actually engaging in those behaviors are experiencing. And so when I moved into working with male identified youth, all of a sudden I saw a lot of kids who I was, had really, really beautiful relationships with, who had also done really, really intense, pretty horrible things. And so I think that just like being able to kind of not necessarily separate, I never want to engage in a way of like separating the offense from the person at all times. But I also think being able to create safe spaces for people who have done really, really horrible things, and being able to view them as three-dimensional people who are actually really can be really funny and really caring and very sweet and very loving, who have other things going on for them, where it wasn't just this evil intent that we sometimes attach to sexual offenses. I think that's both a really beautiful thing that we can kind of come to understanding, but also can be really difficult, especially when you come from a place or a workspace where you're only really seeing folks who have been victimized by that.
Yeah. I mean, beautifully said. And I think part of what I'm picking up on is this, again, distinction between like who someone is and what they've done, and understanding who you're working with as a whole being, and more than just the charges, more than a diagnosis. Understanding they did a bad thing, they're not a bad person, and trying to hold the space for both accountability for their actions and compassion for them as a person, which is like so hard to do sometimes. But yeah, this humanization that you're doing right now is really helpful in refocusing on needs and understanding our roles in care or supervision, or however it is we're working with these people. I am a little mindful of time. I hate to not take questions from people, but I'm wondering if we could sort of move through, we could move through what we have, and then if the questions remain, if we have time at the end, or feel free to email myself or Carly literally anytime. We're happy to answer. So some of the challenges that we highlight here: lack of training and support, maybe not knowing exactly what this work is before going into it, and not having sort of a supportive environment or people you can turn to. A conflict of values, and these are some things that we've spoken about too, that working with folks and developing this compassion can sometimes violate or blur our sense of right and wrong. We tend to think in black and white a lot of times, where we like to put things in little compartments, and so sometimes conflicts arise when we have to see things as gray. This question about who the patient or the client, depending on what you call them, who it is that you're working with, you know, sometimes we're working with the person in front of us, and other times we feel like we are working for children in the community or community safety. And that is a huge burden of responsibility when that happens. Can make it really, really hard work to do, and be paralyzing for some people, or sort of makes it hard to make choices and move forward, and can keep you up at night, frankly, or I should speak for myself, can keep me up at night sometimes, depending on the case that I'm working on. These feelings of isolation, feeling like we cannot talk about these biases as either healthcare professionals, as working in the legal system, caseworks, any kind of support. There are certain expectations of us to remain these unbiased, non-judgmental, these sort of like blank canvases to do good work on. And it's not true. And it doesn't mean that we're going to practice unethically because of that. It means that awareness of those biases and knowing when they're coming up is really important for addressing them with supervisors, with coworkers, so that you can provide care that is non-judgmental and really in the best interest of the client and the community. And this is something that I, you know, could want to scream from the top of a mountain, like every time I talk about my work, is that like this stuff is going to come up, and it doesn't make you bad at your job. It's actually really helpful to know when it's happening. Maybe the next slide, we have personalization. If you have a kid in your life, it can be really, you know, you can have intrusive images of something happening to them. You can, you know, feel really intense feelings towards someone who has harmed a child who's maybe the same age as a child that you know. This seeing the patient or the client as a label, again, I think this is something that both Tammy and Kathleen touched on, this seeing the person for what they did or a diagnosis versus who they are as a whole person. The next point, create distrust of others. This is that vicarious trauma, and, you know, constantly looking over your shoulder, not letting your kid go to another kid's house, however that surfaces. This can be a result of the work. And portrayal in media and society. So again, something that we've touched on, how that translates to our orientation or relationship with the person. We have some slides about our approach here. I might, just given the time that we have, these are pretty, they touch on those things pretty directly or explicitly. So we can leave these for review, just highlighting how communicating and consulting helps process emotions, how understanding your client as a whole person. These are all strategies that we use in sort of addressing these challenges. So we'll leave that with you to review.
Sorry,
And
I just want
yeah.
to say that we will circulate the slides to the members of the HSJCC, and they're going to be uploaded to the HSJCC website under North York and West Toronto resource section. Or anybody could contact me and say, could you give me the slides?
Perfect. Yeah, that would be great. You know, we don't want to leave with all the challenges and say, okay, it's really hard, bye. So these are some like practical suggestions and practical things that we do in order to manage those challenges and whatever comes up, and the importance of self-care and being there for other people who you work with, who work with this population. So I don't know if we have 5 minutes. I'm not sure if we have time to open it up.
Well, thank you so much, Angele and Carly. Thank you very much for agreeing to take questions from anybody who wants to email them to you. We appreciate that. It seems from in the chat there seems to be a lot of interest in some literature. So You mentioned the articles about the neurological brain differences for those with paraphilia. If you could forward to that, we'll get that out to everybody. And
Sure.
also there was a question about any flyers that you might have, especially as they relate to maybe the chat line that we can all share with our clients. That would be really helpful.
Sure. Yes, we do. We have a poster that we can send out.
Fantastic.
Thank
We'll make
you.
sure
That would be great.
for everybody. Thank you.
Sure. Yeah.
So yeah, there's a few minutes left. So if anybody has any questions.
Yeah, I think Alana was next. If you weren't, please, anyone jump in and correct me. I think you're unmuted, Alana, but I can't hear you. Oh.
You have to unmute yourself. Okay, yeah, you're unmuted now. We can't hear you. Maybe you might want to write your question in the chat.
Maybe Catherine, you can go ahead with your question, and then yeah, we'll keep an eye on the chat for you, Alana.
So are you able to hear us now?
Yes.
Hi, I'm Morgan Glass. I'm a psychiatry resident. I'm Ilana's son. Thank you very much for your presentation. I was wondering if you know what percentage of your clients with pedophilia do not have an identifiable sexual trauma in childhood, and if in the therapeutic approach, there's like, is it basically trauma-informed therapy? Do you assume basically that all of your clients do have sexual trauma and that will be part of their recovery to address?
Absolutely. So certainly trauma-informed, not trauma-focused. So we do not do trauma therapy at our clinic. We certainly provide resources for people who are interested, people who we think might benefit from it. Trauma-informed to the degree that it can be. We do run into some issues with folks who are on probation who, you know, our treatment, we work at a hospital. It is voluntary, and at the same time, we know that there can be some consequences if people don't participate in the programming because of orders that they're on or whatever it is, and for good reason. And like, we want to keep people safe. So it is tough to be 100% trauma informed with someone who actually doesn't want to be there. So our approach is certainly we are aware that even if it's not sexual trauma, every single person who's coming in has some kind of trauma. And everyone coming in, almost everyone has been incarcerated. So like that alone sort of guarantees it. But I can't remember ever assessing someone who didn't have some kind of trauma. But in terms of addressing it in treatment, we are limited in that way for resources, sadly. I don't know if that answers the question.
Yeah. Thank you. Yeah, that was very helpful. I was also just wondering, do you know, like, do almost all of the people that you interact with have an identifiable sexual trauma in childhood? Yeah.
I would say it's not uncommon. I wouldn't be able to say in who has like what percentage at our clinic we see. Yeah, that's not a number that I have. The most I can say is not uncommon, I suppose. But I think the childhood trauma ranges from sexual trauma, neglect, physical, so on. And we know that it's not a one-to-one. Like sexual trauma means sexual trauma or perpetrating later. Like oftentimes the connection is could be neglect or physical abuse, and later on the way that the trauma is perpetrated as sexual. It doesn't, just because you've been sexually abused doesn't mean that you will, and not that you're implying that, but I think we see a lot of different childhood trauma, not necessarily only or mostly sexual trauma. Okay, so I see we are at 1 o'clock. I don't know if we want to take one more question or if you want to wrap up, whatever folks think.
I think we're able to take one more question.
Yeah.
Again, just one more reminder, if you could just please fill out the evaluation before you leave, that would be really, really, really helpful. And again, Angele and Carly, thank you so much for agreeing to send some literature and posters so that we can share it with all the participants. There seems to be quite a lot of requests for that.
I'm so glad. It's our pleasure. Yeah.
I just have one quick question, if that's okay. Just wondering, in regards to working in the community as in case management, if we come across a client who discloses to us that they're having these thoughts or feelings, what would your suggestion be for the way that we could encourage them to work towards getting support or help? And if we can fill out the application, I don't know if that's possible, if it has to be a doctor or a psychiatrist. I think you're on mute, maybe.
Is this working? No?
Yeah, we
no,
can.
that's better. We can hear you
Oh,
now.
good. Okay. Sorry about that. I think it depends sort of what they're working with. Like if they do have charges, I think the simplest thing would be for a probation officer or like a diversion worker. If they don't have charges, they can self-refer to the Talking for Change program. Yeah. Thank you so much, everyone, for having us.
That takes us to 1:04. So thank you to our presenters. Angele, Carly, thank you so much. I'm sorry that it was only an hour long, but again, if anybody has any questions at all, they're happy to answer them personally, so you can email them. And we will make sure that we provide all of the posters and literature that they share with us to everybody who participated today. So thanks again. That was wonderful.
Thank you so much.
And thanks also to all the participants for coming to join us.
Yes, thanks, everybody.
Everybody have a wonderful afternoon. Take care. Thank you.